Hello everyone. In this section, we will define schizophrenia spectrum disorder. Before we begin, let me give you an overview of today's presentation. First, I will introduce the concept of schizophrenia spectrum disorder and explain what it means in clinical psychology. Second, we will focus specifically on schizophrenia itself, its symptoms, diagnostic criteria, and underlying mechanisms. Finally, I will discuss other disorders within the schizophrenia spectrum, which share similar features but differ in important ways. Through this structure, I aim to provide a comprehensive understanding of how schizophrenia and related disorders are conceptualized and within abnormal psychology. Schizophrenia spectrum disorder is commonly understood as a form of psychosis, which refers to profound loss of contact with reality and impaired judgment. Importantly, individuals may present with psychotic symptoms of varying severity, duration, levels of functional impairment. Because of this diversity, clinicians classify these conditions into a range of disorders within schizophrenia spectrum. From a historical perspective, Emil Kraepelin in the late 19th and early 20th centuries introduced the concept of dementia praecox to describe early onset psychosis. Later, Eugen Bleuler defines this understanding by emphasizing disorganized thinking and disturbances in reality testing. He coined the term schizophrenia from the Greek words schizo, meaning spilled, and phren, meaning mind, highlighting a fragmentation of mental processes. In Korea context, there has also been an important shift in terminology. In 2011, the Korean Neuropsychiatric Association officially replaced the old term of schizophrenia, 정신분열, with 조현병 in order to reduce social stigma and emphasize the possibility of recovery. Together, these perspectives illustrate how schizophrenia spectrum disorder have been conceptualized clinically, historically, and culturally. Now, let's turn to schizophrenia itself, which represents the core and most extensive studies disorder within the spectrum. Schizophrenia is clinically defined by a wide range of symptoms, which are generally divided positive, negative, and psychomotor categories. First, let us consider the positive symptoms. Positive symptoms refers to the presence of abnormal experiences of behavior that go beyond ordinary functioning. One of the most prominent features is delusion. Fixed false beliefs that persist despite clear contradictory evidence. For example, patients may develop a delusion of reference in which they interpret unrelated events or behavior of others as personal significant. Another common manifestation is the grandiose delusion. Where an individual believes that they possess exceptional ability of status. For example, claiming to be a divine figure. Alongside delusions, hallucinations are a core hallmark of schizophrenia. These are perceptions that occur without any external stimuli, and they may be auditory, visual, olfactory, or even tactile. Among these auditory hallucinations, such as hearing voices, are the most frequent reported. Positive symptoms also include disturbances in thought and language. This is often termed formal thought disorder, characterized by disorganized thinking and disjointed speech. Patients may show loosening of association, where their ideas drift apart without logical connection, or derailment, incoherence, and the creation of neologisms, words that are invented but have no commonly understood meaning. Altogether, these positive symptoms reflect an excess or distortion of normal mental functions, and they often contribute to the striking clinical presentation of schizophrenia. In contrast to positive symptoms, schizophrenia is also defined by negative symptoms, which reflect the absence or reduction of normal psychological functions. These symptoms are often more subtle but tend to be strongly associated with long-term disability and poor functional outcomes. Patients may exhibit limited speech, a blunted or flat affect, diminished motivation, and a tendency toward social withdrawal. Clinicians often summarize these characteristics as using the so-called 5 A's. First, blunted affect refers to a noticeable reduction in emotional expressiveness. Second, anhedonia is the inability to experience pleasure even from activities that were once enjoyable. Third, ovulation describe a lack of motivation or initiate or sustain goal-directed activities. Fourth, apathy represent a pervasive sense of indifference and lack of concern. Finally, ambivalence involves the simultaneous presence of contradictory feelings, making it difficult for patients to make decisions or maintain consistent behavior. While positive symptoms often draw clinical attention due to their dramatic presentation, negative symptoms are equally critical because they underlie the profound social and occupational impairments seen in schizophrenia. In addition to positive and negative symptoms, schizophrenia is also characterized by psychomotor symptoms. These involve abnormality in motor behavior, which can range from subtle disturbances to dramatic alteration in movement. Patients may display repetitive or purposeless movement, unusual and bizarre postures, and stereotyped gestures that appear mechanical or ritualistic. One of the most striking examples of psychomotor disturbance is catatonia, 긴장증. Catatonia refers to a marked disturbance in motor activity, which can manifest as complete immobility and rigidity, or conversely, as excessive and uncontrolled movement. Although less frequently emphasized than positive or negative symptoms, psychomotor features are clinically significant. They are not only affect daily functioning, but also provide important diagnostic clues, particularly when assessing the severity and subtypes of schizophrenia. Now, let us consider the prognosis and clinical course of schizophrenia. The long-term outlook of the disorder varies widely, but several consistent patterns have been identified. A poor prognosis is generally associated with the persistence of negative symptoms and long-standing functional impairment. These cases are also observed more frequently in males. By contrast, when mood symptoms are present and active psychotic episodes are shorter in duration, the prognosis tends to be somewhat better, with comparable risk level between men and women. In terms of onset, schizophrenia most commonly emerges between late adolescence and the mid-30s. It is exceedingly rare to observe first onset before adolescence or after the age of 40. Cognitive impairment may present at the very beginning of psychosis, and in some individuals, it may even precede the onset of overt psychotic symptoms, often persist throughout adulthood. Outcomes also vary. Approximately 20% of patients demonstrate favorable prognosis with partial or even full recovery. However, for many individuals, the disorder follows a chronic and relapsing course. Patients often experience a cycle of relapse and remission, which may ultimately result in progressive functional decline over time. This variability in prognosis underscores the importance of early intervention, sustained treatment, and comprehensive psychosocial support. After discussing the prognosis and course of schizophrenia, let us now turn to its causes. Although no single factor can fully explain the disorder, extensive research points to a complex interplay of biological, psychological, and social influences. First, regarding biological factors, evidence from family and twin studies strongly supports a genetic contribution, highlighting the interaction between genes and environmental triggers. The most prominent neurochemical explanation is dopamine hypothesis, which proposes that excessive dopamine activity underlies the emergence of psychotic symptoms. Other neurotransmitters, such as serotonin, have also been implicated in pathophysiology. Additionally, prenatal and perinatal complications, such as maternal malnutrition, infection, trauma, hypoxia, substance exposure, has been shown to increase vulnerability. Findings from neuroimaging studies using PET and MRI further reveal both functional and structural brain abnormalities. For example, many patients display enlarged ventricles, which are associated with greater cognitive impairment, and social difficulties, as well as reduced volume in frontal and temporal lobes, accompanied by increased white matter integrity and impaired blood flow. Taken together, these biological factors suggest that schizophrenia is rooted in neurodevelopmental disturbances shaped by both genetic predisposition and early environmental risk. Beyond biological factors, schizophrenia is also shaped by the stress vulnerability model, often referred to as the diathesis stress framework. According to this model, individuals may inherit a genetic predisposition or vulnerability that makes them more susceptible to developing the disorder. However, whether or not schizophrenia actually emerges from depends on the degree of environmental stress experienced during critical period of brain development. For example, exposure to significant stressor before, during, and after birth, such as prenatal complication or early life adversity, can remarkably increase the likelihood of onset. At the same time, a supportive and stable environment may lower risk even for those with a strong genetic vulnerability. In short, schizophrenia is best understood not as the result of biology alone, but as the outcome of a dynamic interaction between genetic predisposition and environmental stress. Finally, schizophrenia has also been explained through a range of psychological perspectives. From a psychoanalytic view, the disorder has been linked to regression to early developmental stage when parental care is inadequate. This regression may manifest in exaggerated self-importance, leading to grandiose delusions and even the creation of neologism. Attempt to regain ego control can result in social withdrawal and distorted sense of reality. From cognitive view, schizophrenia is understood as maladaptive interpretation of abnormal sensory experience. Hallucination or misperceptions are often explained and reinforced through delusional thinking. In this sense, cognitive distortions serve to maintain psychotic symptoms. Importantly, early cognitive intervention may help to prevent the progression of the disorder. Finally, family studies have historically emphasized the role of dysfunctional communication and emotional climate. The outdated concept of the schizophrenic mother describes a cold and rejecting parental figure who sent contradictory messages. Building on this, the double-bind hypothesis suggested that mixed signal, such as "I love you but stay away," could increase vulnerability to psychosis. Most recent research highlights the role of expressed emotion, meaning high level of criticism, hostility, or over-involvement within family. These dynamics are strongly associated with higher relapse rate among the individuals with schizophrenia. Altogether, this psychological perspective underscores how cognitive processes and family environment can interact with biological vulnerabilities and environmental stress, shaping the onset and course of schizophrenia. Now we turn to treatment of schizophrenia, beginning with pharmacotherapy. Antipsychotic medication have been the cornerstone of treatment since their introduction in the 1950s. Currently, more than 60 different antipsychotic agents have been developed, most of which act primarily by blocking dopamine D2 receptor. It is important to note, however, that patients with schizophrenia still experience a significant reduced life expectancy, approximately 15 years shorter than the general population. This is partly due to long-term side effects of antipsychotics, but also due to lifestyle factors such as obesity, heavy smoking, poor diet, and medical complications, including organ failure. Antipsychotics are generally divided into two categories. First generation antipsychotics, such as chlorpheniramine, haloperidol, primarily target positive symptoms like delusions and hallucination. Clinical effect can be observed within 24 hours of the initial dose, as dopamine blockade begins within hours. However, the maximum therapeutic benefit often requires weeks or even months. Importantly, their overall effectiveness varies depending on continuous use over the first 2 or 4 weeks. Second generation antipsychotic, also known as atypical agent, include clozapine, risperidone, olanzapine, quetiapine, aripiprazole. Among these, clozapine is the most widely used, particularly because it remains effective even in patients who are resistant to other antipsychotic drugs. Together, these pharmacological treatment remain the foundation of schizophrenia management, but they also highlight the challenges of balancing efficacy with long-term side effects. While pharmacological treatment remains essential, medication alone is not sufficient to address the full range of difficulties associated with schizophrenia. This is where psychosocial approach become critically important. Since the 1980s, cognition has been increasingly recognized as a core deficit in schizophrenia. Even after psychotic symptoms such as delusion and hallucination improve, patients often continue to experience significant impairment in memory, attention, and executive functioning. These cognitive difficulties directly interfere with social functioning and vocational achievement. In response, specialized program of cognitive remediation rehabilitation has been developed. These interventions provide structured training designed to enhance memory, improve attention, and strengthen problem-solving skills. Over time, such improvement contribute not only to better cognitive performance, but also to enhance social relationships and occupational functioning. Ultimately, cognitive training helps individuals reintegrate into a society by supporting both vocational success and everyday social functioning. This approach highlights how treatment must extend beyond symptom control, focusing instead on recovery and quality of life. Another important psychosocial intervention for schizophrenia is cognitive behavioral therapy, or CBT. CBT is designed to help patients critically examine and reframing maladaptive beliefs that underlie delusions and hallucinations. For example, instead of accepting or hallucinated voices as an absolute reality, patients are encouraged to test the evidence for and against their experiences. This process of reality testing reduces the intensity of psychotic symptoms and enhances insight into the illness. In addition, CBT has been shown to lower relapse risk and improve overall social functioning. Patients learn strategies to cope with distressing symptoms, manage stress more effectively, and engage more fully in daily activities. It is important to note, however, that CBT tend to be most effective in addressing positive symptoms. In more chronic cases, where negative symptoms such as apathy and social withdrawal dominate, cognitive remediation or rehabilitation strategy may be more beneficial. Together, CBT and cognitive rehabilitation highlight the complementary ways in which psychosocial therapy supports recovery beyond what medication alone can achieve. Another psychosocial intervention that has played an important role, especially for chronical hospitalized patients, is milieu therapy and token economy. Milieu therapy was first introduced in 1950s by psychiatrist Maxwell Jones in the United Kingdom. It is based on humanistic principles, emphasizing the therapeutic value of a structured, supportive environment. The goal is to encourage patients to take responsibility for their own behavior, participate actively in daily routines, and gradually adapt to social demands. Even today, elements of milieu therapy are still applied in halfway houses and community-based residence programs. Closely related to this is the token economy, where apply behavioral principle of reinforcement. In this approach, patients are rewarded with tokens such as points or symbolic currency when they engage in adaptive behaviors like attending group sessions, completing tasks, or interacting appropriately. These tokens can be exchanged for privileges or tangible reward. Together, milieu therapy and token economies illustrate how environmental structure and behavioral reinforcement can promote engagement, responsibility, and social adaptation in individuals with schizophrenia. Another important psychosocial intervention is individual therapy combined with psychoeducation. Personal therapy in this context is not analytic but rather a structured approach that teaches patients practical coping skills and adaptive strategies. In the earliest phase of treatment, patients are encouraged to recognize the link between their symptoms and stress and to develop basic coping and cognitive skills. As therapy progresses into later phases, the focus often shifts to social and vocational functioning. This includes personalized interventions designed to support and social adaptation, strengthen role performance, and facilitate successful reintegration after hospital discharge. Alongside individual therapy, psychoeducation plays a critical role. By educating patients and their families about symptoms, the importance of medication adherence, and effective coping strategies, psychoeducation reduces relapse rate and fosters a collaborative recovery process. In summary, individual therapy and psychoeducation together empower patients with both skills and knowledge, enhancing resilience and long-term outcomes. Another critical component of psychosocial treatment is case management. Case management is essential for rehabilitation because it helps patients function more effectively within their communities. The focus is not only on clinical care but also on connecting patients with the necessary services they need, such as housing, vocational support, medical treatment, and employment opportunities. Community treatment, or ACT, this approach involves a multidisciplinary team and may include psychiatrists, clinical psychologists, social workers, and nurses. The team provides intensive, continuous, and individualized support, ensuring that patients do not fall through the cracks of fragmented healthcare system. By coordinating care and offering consistent case management, this model reduces hospitalization rate, improves social integration, and enhances overall quality of life for individuals living with schizophrenia. Building upon case management, another key psychosocial approach is social skills training, or SST. SST is designed to teach essential interpersonal and practical skills that patients need in their daily lives. This includes conversational skills, vocational abilities, and even strategies for managing medications and symptoms effectively. The training often focuses on very specific behavior, such as maintaining eye contact, using an appropriate tone of voice, and expressing oneself clearly. Patients are encouraged to practice these skills through structured role plays and corrective feedback. Importantly, the goal of SST is not limited to practice within therapy sessions. It emphasizes the generalization of skills into real-life situations, helping patients interact more effectively with others, improve their social confidence, and ultimately function more independently in their communities. Finally, Let us look at psychosocial rehabilitation, which represent a broader shift in how we understand and treat schizophrenia. The traditional medical model primarily focused on pathology and symptom reduction. While this approach is valuable, it often overlooks the patient's capacity for growth, adaptation, and fulfilling life. In contrast, rehabilitation model emphasizes individual strength. The goal is to help a patient achieve a satisfying and meaningful life within the reality of their environment rather than only reducing symptoms. Since the 1950s and 1960s, major policy changes in the United States and Europe mandated community-based care for people with mental illness and intellectual disabilities. This reform marked the beginning of the community mental health movement. Thus, psychosocial rehabilitation integrates medical treatment with social support, education, and empowerment, ensuring that recovery is not only about symptom control, but also about restoring dignity, autonomy, and quality of life. Now, in this section, we'll explore other schizophrenia spectrum disorders. Let us begin with schizoaffective disorder, 조현정동장애. This disorder is characterized by the combination of psychotic symptoms and mood disorder symptoms. For diagnosis, the patient must meet criteria A for schizophrenia, along with the major depressive or manic episode. Importantly, mood symptoms must cover a substantial portion of the illness duration, and psychotic symptoms can vary across different stages of the illness. There are two main types. Bipolar type, which is more common in early childhood, and depressive type, which tends to more common in older adults. Next, let us examine schizophreniform disorder as defined in DSM-5. For diagnosis, at least 2 or more symptoms must be present for a significant portion of time during a 1-month period. Importantly, at least one of these must be delusion, hallucinations, and disorganized speech. The symptoms include delusion, hallucination, disorganized speech, such as frequent derailment or incoherence, grossly disorganized or catatonic behavior. Another key diagnostic feature is the duration of the episode, which must last for at least 1 month, but less than 6 months. Now, let us move on to delusion disorder, 망상장애. This disorder is characterized by the presence of persistent, non-verbal delusions lasting for at least 1 month. Compared to schizophrenia, the clinical course tends to be more stable. There also appear to be a possible familial tendency, particularly with features such as suspicion or jealousy. Importantly, clinicians must carefully rule out substance use or medical causes, such as stimulant use or brain disease, which can mimic delusional states. Patients with delusional disorder often maintain better overall functional than those with schizophrenia, although in some cases the condition may progress. Unlike schizophrenia, these patients do not typically present with prominent psychotic symptoms such as severe disorganization or marked hallucinations. This distinction helps differentiate delusional disorder from schizophrenia. Finally, let's discuss brief psychotic disorder, 단기 정신병적 장애. This disorder is defined by the sudden onset of psychotic symptoms, typically within 2 weeks, without a prodromal phase. The symptoms are intense but short in duration, lasting anywhere from 1 day to 1 month, following by a full recovery. Patients often experience severe distress, confusion, and intense emotional shift. Although brief, the episode may still cause significant functional impairment during its course. Epidemiologically, brief psychotic disorder occur about twice as often in women as in men. Risk factors include having a schizotypal or borderline personality disorder, psychotic proneness, and negative affectivity. Because of its short duration and good prognosis, this condition is distinct from other schizophrenia spectrum disorder. So, in this section, we explored the broader spectrum of schizophrenia-related disorder. While schizophrenia spectrum disorders are complex and often chronic, research and clinical practice show that with comprehensive, individualized treatment, many patients can achieve meaningful recovery and improve quality of life. I hope this lecture have given you a clear understanding of schizophrenia spectrum disorder and their management. Thank you for your attention.